Hello, Capital Area Parkinson Society members and participants. My name is Ariel Goward and I am one of your VPs and I serve on the board. We hope everyone is staying safe and sane during these unprecedented times, and we just want you guys to know that we're here for you. So please reach out and let us know if there's anything we can do to help you as members. Hopefully you've been getting calls from some of the board members letting you know about some changes and updating you on what's going on. One of the big things we changed this year is asking for people to pay their dues in the beginning of the year as opposed to the end of the year. So if you have not already paid your member dues, please go online and do so. We're also going to be changing how you get the newsletter, and it's going to be online and only mailed out to members. So we're reaching out to make sure we have your current address and want to see what your preference is. We are happy to have Corinne Jones, who's also a board member and a faculty member at UT, speak today on respiration, voice, and speech in Parkinson's disease. Next month, we're going to have Damon from Aging is Cool come and present to you guys. And they've given us 2 topics, so I wanted to throw it out to you guys as the members to see if you have a preference. So the 2 suggestions were Damon would present on brain health and do brain games with you guys, or he could talk about physical activity and do some chair fitness classes. So if you have a preference, please reach out, email, or call the CAPS office. You can reach the CAPS office at 512-371-3373. We also wanted to let you know, please reach out for more resources or help getting through these challenging times. Medicare recently added telehealth visits in order to keep seniors safe, and we see that social distancing can lead to an increase in anxiety and depression, and those are all symptoms that a licensed clinical counselor could help address. So if you would like more information or would like to be connected with the therapist, please reach out to the CAPS office. Again, that number is 371-3373. And Medicare should cover most of it. There's some will have a small copay, but through our CAPS Cares program, if you're unable to afford it, we would love to help you get these needed services during this time. If you need anything, again, reach out. We're going to be posting online resources, videos, CEUs, and links to other Parkinson's support groups that are putting out virtual things for their members, that you guys have one place to access everything and can hopefully get the support and online classes and needed exercise. So enjoy this presentation, and again, reach out if you have any suggestions or need anything from us.
Hi, I'm Corinne Jones. I am an assistant professor at the University of Texas at Austin. Also, I am a speech language pathologist by training. Most of my clinical work is done in people with swallowing disorders. However, I do have a little bit of expertise in voice and speech as well, particularly in Parkinson's disease. And I'm really glad CAPS invited me today to speak to you. I hope you are all doing well, being safe, and sort of getting used to this new normal. I know it's taken me a little while, and I'm still probably not 100% yet in a routine, but I'm doing my best to keep everyone else and myself and my family safe. So today I'm going to be talking about respiration, voice, and speech in Parkinson's disease. These 3 things are very interrelated, and they're really important for verbal communication. And so my disclosures: I am an employee of UT. I also see patients at UT Health Austin. I am on the board of CAPS, and I do have research grant funding from the American Speech Language Hearing Association Foundation, but that funding has nothing to do with what I'll talk about today. Also, I presented some of this information at the 5th World Parkinson Congress last summer in Kyoto. So I also spoke to the CAPS membership last September, the things that I have presented at this Congress. So you might be thinking that this is familiar, but this is a slightly different topic than I talked about prior. So just an overview of what I'll be talking about today. I'll first review normal anatomy and physiology, so normal structure and function for respiration, voice, and speech. And then I'll give a brief overview of how we evaluate each of these 3 things, what we look for in people with Parkinson's disease, and how we approach treatment. This is sort of a global overview, and just note that all of these evaluations and treatments are very specific to each individual. So first, starting off with anatomy and physiology. So in order to speak, we need to do a few things. We need to first figure out what we want to say. So I need to formulate my ideas and to get them in the correct order, find the right words. That's more of a cognitive linguistic task. So I have it in parentheses here because that's not really exactly what I'll be talking about today. So once we've figured out what we want to say, then we have to breathe air in. We breathe air out. Sometimes we refer to that as the power source. So that's why I'm bringing respiration into this voice and speech talk, is because that respiration is really the underlying power for our communication. Then we close the vocal folds, sometimes referred to as the vocal cords. We close them in order to create sound, and actually it's a vibration that creates the sound, and so that's called the vibrator. And then we move the articulators to shape the sound. So once we are creating sound, we shape it in different ways by moving things in our mouth and our throat. And that's what we call resonators as well. So respiration is referred to as the respiratory tract. That's our anatomy. It's separated into upper and lower. So the upper respiratory tract, so you can see my mouse here, the upper respiratory tract is the nose. This is sort of a cross section of the head and then looking from the front through the lungs. But our upper respiratory tract includes our nose, our mouth, our throat, what we call the pharynx, and then to our voice box, what we call the larynx. Once we go below the voice box, and it's considered the lower respiratory tract. So that's the trachea, the windpipe, which when it separates into left and right, it's called the bronchus or bronchi. And then those tubes will split further and further and further apart in the structures, what we think of as the lungs. Finally, they'll split and split and split to what we call down here, up here, this is the alveoli. So there's these little sacs. They kind of look like bunches of grapes. And this is where gas exchange happens. So this is where we get connection between the air we breathe and the blood in our body. So this is where we have oxygen goes into the blood and then carbon dioxide is taken out of the blood. So when we inhale oxygen in, that goes into the blood, and when we exhale mostly CO2 out. Other really important structures that are not necessarily considered part of the respiratory tract, but are necessary for respiration, are the diaphragm. So this is a large muscle that attaches to the bottom parts of the lungs. The diaphragm, fun fact, when we get hiccups, it's actually a little spasm in this diaphragm. The rib cage is really important. That protects our lungs. It also gives some structure for the lungs to attach to. The lungs are, or the rib cage is not depicted in this photo. And then there's also muscles that attach to the rib cage, which help the lungs move. So in order to breathe, there's both inhalation and exhalation. Inhalation is usually active unless we're asleep or unless we're just quietly resting. It's usually an active process. We have to actively contract muscles. So when we do that, when we have this active muscle contraction, we contract the diaphragm, which is depicted here in the lower part of the screen in this darker red. And we also contract our chest muscles. So when we contract our diaphragm, that moves down. When we contract our chest muscles, that moves out. And the reaction from this contraction is an increasing in the lung space. So if you think back to your physics classes, if you have an increase in volume of a container, the relative air pressure in that region is going to go down. And so they'll have a pressure gradient from the outside air into this increase in lung air, so air will rush in. So we're making this space bigger, so air comes in, and then that's inhalation. And then when we exhale, it can be either passive or active. So what do I mean by that? Passive, so if I'm expanding, I'm contracting these muscles to create this large space, and then I just relax and it comes down. there's a lot of elasticity to the tissues around the lungs, and so it doesn't want to be stretched too much, and so I can just relax the muscles and I'll decrease that space, which creates a relatively greater pressure, greater than the air outside, and so then air goes out. Consequently, I can contract muscles, so I can contract my abdominal muscles to bring that diaphragm up, or I can contract the chest muscles in a slightly different way to contract to send air out. Anytime I'm speaking or coughing, that's an active contraction. I have to really actively control and volitionally control those muscles. We can also just sit as we're sitting. We can actively take control of that. It's not just necessarily a relaxation of the muscles. So one thing, again, that's important to take away is that anytime we speak, we have that active exhalation. All right, so now moving on to the voice box, the larynx. It's a complex of different cartilage structures. There's lots of different muscles within the voice box, and then also different soft tissues. And the primary structure that is needed within the larynx for creating voice, creating that sound that we hear, is called the vocal folds. We call them vocal folds in the biz, but oftentimes people call them the vocal cords. They're the same things. They're not cords of tissues. They're more, flaps or folds of tissue. And so that's usually what we say. In the picture on the left here, we see a cross section of the head. We have the nose here and the lips and the tongue. If we go down on the front side, this in the green and blue and pink and white, this area is the larynx. It's often sort of demarked by the Adam's apple. If you have a large larynx, you have a large Adam's apple. The structures are not actually green and blue. This is just for demarcation on this page. Here's a zoomed in version. Again, it's kind of cut down the middle, but there's different cartilaginous structures and they sort of work in different ways. And then you can take a look from the top. You can either put a little mirror in your mouth, or if you put a camera in your mouth or up your nose, and we can get a top-down view of the larynx. And that's what we see on the right here. So we can see some of these structures in pink here. And then these white bands, these white lines, those are the vocal folds. So in you and me, they actually look pretty white if they're healthy tissues. And then they've got these nice straight edges. When we breathe, they have to be separated out so air can get into the trachea. But when we voice, they actually come together. So I have that described here. So in order to produce voice, we breathe in first, but then we have to voluntarily close those vocal folds. And when we breathe out, when we actively breathe out, we'll send air through those closed vocal folds, and then they'll vibrate. And we can change the pitch of the vibrations by changing the length of the vocal folds. So we can tilt our larynx back and forth. We don't necessarily think about it as tilting, but we get a lot of practice on how to do this. And if we have a faster vibration of the vocal folds, that means we have a higher pitch. Or if we have a slower vibration of the vocal folds, that results in a lower pitch. So this is a cross-section now from the front. This is one vocal fold here and another vocal fold there. They're volitionally brought together. When you send air up through them, they'll start to come apart, and then air will come in. And since the air is moving very fast, there's a physics principle called the Bernoulli effect that they'll go apart and then they'll snap back together. And then they'll repeat this vibration pattern over and over and over again. And then you have this sort of pulsing of the airflow, and that's what's translated into sound. So if we're to watch this from above, we can see these white bands here. Those are the vocal folds. And as this person's phonating, you can see them flap back and forth. This person actually is taking a breath in the middle. See, they're breathing and they go apart and then they vocalize again. So these are vibrating nice and evenly. And there's no sort of structural damage here. And you can see they're actually kind of white looking. And these look like healthy vocal folds. So now we've breathed in and we've breathed out and created some voice. Now we need to shape the sound. If I don't do anything with my mouth or my throat, you don't get much meaningful information. So the articulators and the resonators actually create the sounds that make up our language. Any language that we are making, unless we're speaking sign language, then we don't need any voice or speech. But in the English language, we use a few different articulators. We use the lips, we use the teeth as articulators. We use the tongue. The tongue is one of the primary articulators. It's actually quite skilled in how it moves. We can move different parts of the tongue and they can contact different parts in the mouth. We have the hard palate. So if you feel with your tongue on the roof of your mouth, you can feel it kind of feels bony. So that's your hard palate. Some people can draw their tongue to the back of their mouth, and some people can feel where it kind of gets soft. So it's not depicted very well in this picture, but the front, about 2/3 has that hard palate, and then it transfers into a soft palate. Sometimes we call that the velum. And the soft palate is very important for our speech sounds. So those are articulators. When we think of resonators, so how the vibrations, how the air vibrates in different chambers of our mouth and throat can impact how a sound sounds. So most of the time in English, we are sending air through the voice box, through the throat, the pharynx, and through the oral cavity. So most of the time when we speak, the velum is raised up and there's not much air going through the nasal cavity. However, we have a few sounds in our language that instead of sending most of the air through the oral cavity, actually most of the air goes through the nasal cavity. These are called nasal sounds, aptly. And they are M, like the M sound, or the N sound, or the sort of NG, ING sound, ing. So most of the air is actually going through the nose. And you can test this. You can test whether a sound is an oral sound, so most of the air is going through the mouth, versus a nasal sound by plugging your nose. So if I say ah, and I plug my nose, ah, it doesn't sound much different. I kind of have an upper Midwestern dialect, which is a little more nasal than some of the other ones. So you can hear a slight difference, but you don't hear overall much difference. However, if I say and plug my nose, it's quite different. So So in those nasal sounds, most of the air is coming through the nasal cavity. Just a little fun party trick for you. So to create speech, first you have to inhale, and then you exhale and produce voice, and then you move those articulators to shape the sound. What we see here is an MRI of someone speaking. And so you can see the lips here, the teeth. This is a better view of the hard palate. And you can see the soft palate. It's most of the time raised up, but sometimes coming down. You can see that tongue moves quite a bit. It's rocking back and forth in the mouth. We actually are pretty skilled with our tongue, and we get a lot of practice in how to use it when we're growing up. Just on here, it's a little bit harder to see on an MRI, but the larynx, the voice box is down here. So we don't get a good view of the larynx with this, but we do get a nice picture of the articulators. This is just sort of a fun visualization. Typically, we would not do an MRI to assess speech. All right, so now I'm going to transfer into how we evaluate respiration, voice, and speech, what we look for in people with Parkinson's disease, and how we treat it. And I'm sort of lumping these all together for respiration, voice, and speech, just so you don't have to hold too much information in your mind. So overall, in Parkinson's disease, voice and speech impairments primarily are present in about 90% of people with Parkinson's disease. That doesn't mean that people can't communicate at all. It just means that normal functioning is a little bit impaired. Respiration, voice, and speech are all motor tasks. So we all have muscles, and we have mostly voluntary control over those muscles. And so just like moving anything with the limbs or with walking, they're impacted by the motor signs of Parkinson's disease, just like any other motor task. Also, we see in people with Parkinson's disease, there's a reduced internal cueing. So if I think I'm speaking at the normal tone and normal loudness, someone else might have a really hard time hearing me because actually I'm speaking very quietly. Parkinson's disease can impair automatic movement, so really overlearned movements like walking. Speech is a very overlearned movement. And also, people with Parkinson's disease have alterations in sensory processing and time processing. We actually use a lot of sensory information when we speak. We need to know, where our tongue is in our mouth in order to produce the correct sounds. We don't consciously think about it, but it's definitely in there. Unfortunately, levodopa type drugs and deep brain stimulation don't greatly improve respiration, voice, and speech in people with Parkinson's disease. So a lot of times we have to rely on behavioral treatment. Respiration, voice, and speech, all three are impacted by normal aging. So we have to layer that on top of Parkinson's disease as well. I'm gonna take a quick drink of water here. All right. So if there's an issue or people want to look into respiration, the specialists that they may see would be a pulmonologist. Those focus a lot on the lower airways. The respiratory therapists are also quite active in the lower airways and can work both in inpatient and outpatient settings. And then otolaryngologists, your ear, nose, and throat, or ENT doctors, they specialized in the upper airways. So again, nose, mouth, and throat into that voice box. So how do we evaluate the respiratory tract? We can do a bronchoscopy. So taking a scope, a little camera that goes through the mouth, through the voice box, the larynx, into the trachea, into the bronchi, the sort of branches of the lung, and then they can have a look around and see the structural integrity of the lungs. Just because you need a really specific position of the neck for this, and you have something going through your mouth, these are typically done when you're asleep, when you're under sedation. We can do spirometry, so you're gonna breathe out forcefully into a sensor here, and this measures the speed of respiration, so how fast are you exhaling? You can measure inspiratory or expiratory pressure, so you're, again, maximally blowing out or breathing in, and this instead of measuring speed, it measures the effort, the pressure, how forcefully are you exhaling or inhaling. And also we can look at pulse oximetry. So you'll see this quite often in the hospital, but it can be done in clinics as well, as how much oxygen is getting into the blood. Respiratory changes we see in Parkinson's disease, any difficulties can be caused by an upper airway obstruction. So any part of the airway that is smaller than we want it to be. Restrictive respiratory dysfunction, so restricted movements of the lungs. Or we have abnormal central nervous system, so how the brain and the brainstem are controlling the breathing, the pattern of the breathing, or the muscles that are responsible for breathing. So we might see symptoms like shortness of breath. The medical term for that is dyspnea. You might see noisy breathing, what we call stridor. You can see sleep apnea, respiration, swallowing and coordination, or a decreased cough efficiency. You just can't get that power behind the cough. And in order to rehab that pulmonary function, typically what we can do is inspiratory muscle training. So inhaling as forcefully as you can to increase the power of those muscles, or expiratory muscle training. So breathing out as forcefully as you can. And then I also have in parentheses aerobic exercise. So anything you do that gets your heart rate up and gets you breathing a little bit harder, that can increase the function of your lungs as well. All right, now moving on to voice. Our voice specialists are our ENT doctor and speech language pathologist. These are the primary people who will be evaluating and treating voice complaints. How do we look at voice? We do a laryngoscopy. So this is similar to the bronchoscopy, but we're looking at the larynx. There's a couple different ways we can do this. We have a rigid laryngoscope. So it's a camera on the end of this rigid thing. This goes through the mouth, and then you can look down into the larynx. Or there's also a flexible scope, which goes up through the nose and down. Here, there's a camera at the end, and then we can look at the larynx. So this lets us evaluate the structural integrity of the upper airway, and then we can also look at how the vocal fold moves. So when I was showing you that video of the vocal folds flapping in the breeze, that was a laryngoscopy. Sometimes we call that a stroboscopy. Unlike the bronchoscopy, you have to be awake for the laryngoscopy, especially when we're looking at vocal fold movement. It's really hard to get someone to voice or to speak when they're under sedation. So oftentimes, so if they go through the nose, you might get some numbing medication in the nose. But again, we want you awake and we want you participating and all that. It's not the most comfortable thing, but it usually doesn't last that long. Also, we can do acoustic or aerodynamic testing, and that looks at the voice function or efficiency. So you can usually put this air sensing mask up into your face, and then you do different voicing tasks, and it can measure the airflow as you're voicing. So how much air is leaking out when it shouldn't be leaking out, or how efficient are you at using your voice? Also, we can do different perceptive rating scales. So just have a conversation or have people read certain passages, and then we use our ears and our minds to sort of give different ratings of different perceptions of how the voice sounds. Voice changes in Parkinson's disease can be caused by reduced vocal fold closure. So if those vocal folds aren't quite meeting together, if there's a little gap, then that can lead to some inefficiencies. If the vibrations are not symmetric, that can cause voice problems. If there's reduced neural drive, so from the brain and the brainstem to the voice muscles, or even if there's altered respiratory patterns. Again, like I said, that respiration, you're breathing, that's your power source. And so if you take away the power, you can take away some of the voice. What we see in Parkinson's disease might appear as a soft voice. We call that hypophonia. You might have a breathy or a pressed or a strained voice. We call that dysphonia. You might hear a vocal tremor. There might be a higher sort of baseline pitch or a decreased pitch range. So how low to how high you can go might decrease. And then you might have voice breaks. So your voice actually just stops or it cuts out at a certain point. So how do we address voice? There are a couple different medical or surgical approaches. Thyroplasty is a surgical approach that an ENT would do, and that brings the vocal folds closer together. So then it's a little bit easier to get them to vibrate. And that's a permanent type of surgery. Something that's a little less permanent is to do a vocal fold injection. There's a few different things that can be injected into the vocal folds that are safe and that allow for good vocal fold movement and vibration. And then that is also done by an ENT. And then you may see a speech pathologist for voice therapy, and that's really focusing on how you're producing that voice in that vibratory segment. And then now for the articulation, really the speech specialist is that friendly neighborhood speech language pathologist. It might be the same person who's assessing and treating for voice or for swallow. We wear many hats. So what we might expect in a speech evaluation, it's a lot based in perception. So what do I hear about your voice? Is more air going through the nose than should, or is less air going through the nose than it should? Or intelligibility. So if you read a paragraph, how much of that can I understand? So again, it's not the voice, it's not the breathing, it's the actual speech. How are you moving those articulators in order to shape the sound? We can also do acoustic testing. So speaking to a microphone, we can look at different characteristics of vowels and consonants. We can do some fun things with the sound waves that you produce. Then we can also look at pitch and how that pitch is inflecting as you speak. And interestingly, there are some new studies that are using machine learning techniques to detect speech changes due to Parkinson's disease. So there are studies where you can call and you can leave a message, and then from that voicemail, the audio file, they can try to detect whether or not you have Parkinson's disease. That's not necessarily used clinically, but I thought it was cool and something fun to include here. So speech changes in Parkinson's disease, the difficulties are caused by just general motor changes due to Parkinson's disease, but also reduced effort. So again, that's that internal cueing. You may feel like you're speaking fine, but people think you're super quiet or you're speaking really fast or really slow. Also that reduced respiratory power. So if you're not getting much out, you might not have as good speech as well. What we might see is a slow speech rate, just like other movements are slow. We might have unclear speech. So the consonants that you speak are imprecise, or the vowels are a little distorted. Typically in Parkinson's disease, we refer to this as hypokinetic dysarthria. That's our medical term for that. We also see what we call spastinated speech. So that's speech that starts out slow or at a normal pace, and as you speak, it gets faster and faster and faster and faster and less precise. So you might, at the beginning of a sentence, be totally understandable, but then near the end, I didn't catch that. Also, sometimes we see stuttering in people with Parkinson's disease. We call that disfluency. We also see reduced pitch inflections or that monotone voice in Parkinson's disease. So how do we address speech in Parkinson's disease? We do it with speech therapy. We've found in Parkinson's disease that speech really improves when you get cueing from someone else. It's really hard to tell from your own person if you're doing okay. So we really rely on someone else. So that's why a speech therapist is often the one to help. And there's a couple really strong programs that have good evidence base that's improved speech in Parkinson's disease. One of them is called the Lee Silverman Voice Treatment, or LSVT Loud. Another one's called Speak Out. And these are specific training programs, and they're intensive. So they're 4 or 5 days a week for 4 or 5 weeks, and you are systematically increasing the intensity with which you're speaking. You speak with intent. These programs are, again, slightly different, but sort of built off of the same principles. And you can either go to the Lee Silverman Voice Treatment website or the Speak Out website, and you can type in Find Therapists in Austin, and you can get a list of therapists who are certified in both of these treatment paradigms. And I have this under speech treatment, but actually it's been shown that going through these paradigms not only improves speech, but it improves voice, and it improves respiration. So it works on the whole system. It's all connected, and we need all of them for clear communication. So I have it in speech, but it's not primarily a speech thing. And then also there's the Speech Vive. This is a little earpiece that's worn all the time or whenever you're having a conversation, and it builds on what we call the cocktail party effect. So if I am in my quiet home office like I am now, and I'm having a conversation, I won't necessarily be speaking very loud. But if I go to a crowded cocktail party, which I'm not doing right now, but if I were going to a crowded cocktail party without even thinking of it, because sort of background noise is louder, I would increase my loudness just without even thinking of it. Totally subconsciously increase my loudness. So what the Speech Vive does is it just puts a little bit of white noise in your ear, and then without thinking of it, you speak louder, just to speak over that noise you hear. This works really well for some people. It doesn't work as well for others, but it's an easy, non-invasive treatment to improve, again, respiration, voice, and speech. All right, so that's all my content. In conclusion, vocal communication requires interplay between respiration, voice, and speech. Again, it's all connected, but they are different anatomy and physiology and evaluation and treatments for each sort of item in the series. All can be impacted by Parkinson's disease, and evaluation and treatment are specific to the needs of the individual. So one person might benefit from respiration therapy. The respiration is really where the breakdown is. One person may have some vocal issues and need a vocal fold injection, and then they're fine. They don't need any other treatments. And some people really would benefit from that speak out or the LSVT loud. I just wanted to take the opportunity to promote some voice exercise for people with Parkinson's disease. A lot of speech therapy offices are closed in this current pandemic, but this group is doing Zoom and Facebook Live exercise programs for voice. This is voice, but it's going to target voice, respiration, and speech. And you can see here a link to sign up. This is led by Stephen Darrow. He's a local speech pathologist to Austin. And it looks like they have a once a week thing for the time being. And so if you're interested in getting some voice exercise, if you're sitting at home all day and not as social as you like, you can get some voice exercise from the comfort and safety of your own home. Thanks for watching. Please don't hesitate to reach out with questions. I apologize we couldn't do a live thing where you could answer my question or ask questions in a live way, but please send me an email. This is my email address. I check it multiple times a day, probably more than I should. So if you send me a question, I will get back to you as soon as I can. And then also, if you're interested in the World Parkinson Congress, it's an every 3-year event. And so the next one is in June 2022. So everything with international travel should be back to normal. And if you haven't been to Barcelona, it's a really beautiful city. I plan to go. And it's a really interesting conference. There's both patients and doctors and scientists and caregivers and lots of different activities and academic sessions and things, guided tours of the city. It's a really quite an amazing experience. Coming up, please don't turn off the video now. We're gonna have some stretching for you. So you've been sitting for however long I've been talking, and now it's time to get up and to get that blood flowing and to do some stretching. You may also be able to do some of this from your seat as well if you don't want to get up, but thank you again and stay safe.
Hey there, my name is Mike Groth. I'm a personal trainer and movement specialist here in Austin, Texas. I've owned and operated my own personal training company here in Austin for the last 10 years, and I work with primarily a lot of individuals with joint and muscle pain, stiffness, and anything that kind of gets in the way of not allowing them to kind of do the functional activities that they want to be able to do, be that hiking, walking, running, even just kind of the simple things like getting up out of a chair without knee or back pain, going up and down stairs, and just basically enjoying all the facets of what we need to be able to do in everyday life. And so one of the biggest things that I kind of like to really place an emphasis on when I'm working with my clients is the importance of good three-dimensional movement at our key specific kind of joints in our body that matter the most as far as torque conversion and freedom of movement. And that kind of really resides at the ankles and the feet, the hips and the thoracic spine. And for a lot of folks over the course of time, due to our chairborne society, due to sedentary lifestyle, due to the workplace environment, whatever it may be, gravity acts down on all of us in a very uniform fashion. And the things that we do or that we don't do to combat that really makes or breaks the quality of our life and being able to enjoy the things that we want to be able to enjoy. And so one of the key things that I really try to focus on with my clients is working on having good, clean motion, especially through the hips. And so for this series today, this is really for anyone who is experiencing some tension, maybe through their hips, maybe experiencing some kind of freezing up, like a lot of people who have Parkinson's, especially, they kind of lose out on their ability to actually translate their body weight forward and backwards, left and right through space confidently, and rotationally as well. And so this little series here I want to kind of take you through is going to help initiate the process to unravel a lot of that tightness and to provide an opportunity for freedom of movement and to help you enjoy a better quality of life. So without further ado, I wanted to kind of show you guys what these movements look like. And we'll just go through kind of a couple of them here. And so what we'll kind of need, and especially in today's society with, what we're dealing with COVID, where a lot of us are kind of stuck at home and we don't really know what to do to help out our tissues or just help our body function better. And so one of the first things I like to do is just try to help a person open up their hips. And one of the best environments we can kind of allow that to happen would be to have a staircase and a railing and a wall to kind of hang on to, and just a gentle kind of split stance hip mobilization where you're just slowly rocking forward and backwards. And notice how when I'm doing this here, I'm just going to try to keep my back leg kind of straight, and I'm just going to drive my knee forward. A lot of people, when they're doing this, they really kind of try to drive with their chest, and it's not really going to give them the same kind of reaction as if they let their hips kind of guide the motion before the chest goes forward. And so this will kind of really help place a bigger emphasis on the hips, both front and back. And so maybe we go for about 10 to 15 reps going forward or backwards. And then we're just going to do a nice and easy 10 to 15 reps going side to side. Okay? And so we'll say we get about 10 or so reps there. And then the final one, I'm just going to have my hips rotate a little bit left and right. And while I'm doing this here, I'm not falling forward with my chest. I'm just trying to keep my torso up nice, tall, and proud. And I'm letting my foot kind of roll as I allow my pelvis to kind of rotate as well, left and right. Okay? And so we go through that sequence, not only on the right leg being down, but then also on the left leg. And so kind of working through that, if you can imagine if we're walking, when my right leg is back in space, I need to be able to allow my pelvis to travel forward ahead of a leg that's still kind of lagging behind that pelvis to actually be able to get a proper load to explode when I'm stepping and I'm walking, or be it running, be it going up and down stairs. We need to have that motion capability within that hip. Now that's kind of more of the front side of the hip. Now the back side of the hip, what we can kind of do here, and actually get a pillow, because this tends to be a little bit more challenging for some people. And so what we can kind of do to make it easier is to put a knee onto a surface so that's nice and comfortable for the down knee. And if it's not that comfortable and you still feel pressure, just add more pillows. Okay? And then from this kind of beginning position, I would just bend my knee just a little bit, so I start to feel a little bit of tension on the underside of my thigh, and I can still hang on here. And I'm just going to go with a chest drive. And as I'm kind of doing that chest drive, I'm just going to try to see if I can keep my knee in the same spot in space as I'm going up and down. Okay? And so I would just kind of repeat that again, high repetitions, 10, 15 reps. And of course, I don't need to go all the way down in here. Maybe I just go like this. Okay? But either way, as I'm going through this kind of cycle here, I'm trying to see if I can keep my knee in the same spot, and I'm just getting action from my pelvis. Okay? So maybe 10 or so reps, 10, 15 reps. After that, take up the motion into this forward flexion, and then you're just going to go a little bit left and right. And as I'm going with this left and right action, I'm letting my hips go left and right. I'm trying to see if I can keep my knee bent so I can keep that tension kind of in the back of the thigh. I feel my muscles back here kind of working. And hey, listen, if it's too challenging there, just lift up a little bit taller with your chest. You're still going to get benefit from here. Okay, so that would be our side to side. And then finally, I'm going to just take my hips and I'm going to rotate in each direction. Okay, and so that's the sequence there. So I'll work on that one with a lot of clients to help them out in easing up their ability to have both the muscles on the front side the front side and the back side of their leg and their hip to be able to open up and to be able to turn on those muscles to allow the person to have better force propulsion, better excitability within the muscles, more power, more strength, and less pressure being put on these joint structures above and below the hip so that we can get our powerhouse, our main big torque converter area in our body, our hips, to be able to actually function properly. Okay, so for this next sequence, what I wanted to kind of go over is some moves that we can do for your upper back. And this is a very key one for a lot of people. We have some stiffness, especially through rotation. And when we're moving our bodies, reaching for something, reaching and rotating for something, if we don't have the motion available at the back, usually the low back, or the upper back, the low back will take over the hit, maybe some shoulder pain, maybe some hip or foot pain or knee pain as well. So what I want to kind of do through this sequence here is to work on pre-positioning the trunk into rotation. And I can start off more into here to make it easier, and I can make it more challenging where I'm more rotated by moving further forward. Okay, so I'm going to start nice and easy first, and while you have your upper body pre-positioned, you're just going to move your lower body through a hip drive. And so as I'm kind of going with this forward and backwards motion, I'm just letting my hips kind of lead the way as my upper body is staying fixed. And then I'm going to go with a pre-position where I feel the most kind of pull. For me, it's going to be kind of squatted down and back. And then I'm just going to go with a side to side. And then I'm going to add in subtle rotation, especially when I'm rotating away. I feel a big pull throughout my back. Okay, so same kind of concept, 10 to 15 reps each plane. And then you can go ahead and work the other side doing the same kind of sequence. Usually people feel one side a little bit more than the other side. And so that side where you felt more restricted, you want to work that side a little bit more. Okay, be it right, left, or be it to the right. So I hope these little kind of movement sequences have helped out. I hope they kind of make sense. Body has a big kind of set of 3 torque converter areas in our system, our kinetic chain: ankles and feet, hips, and thoracic spine. If we keep those free as far as motion goes, remember, motion is lotion. And so if we don't have good quality motion and we have stiffness, stagnation, freezing up, it behooves us to actually regain that motion and then translate it into more functional movement through a progressive exercise and movement-based program. But this is just kind of like a scraping the surface, just wanted to kind of get you your taste buds a little bit wet, understanding that 3D functional movement is the base for any and all functional-based activity, be it walking, running, just going up and down the stairs, getting up out of a chair. Free up your tissues, and you're going to have more freedom to do the things that you want to do and enjoy in life. Again, my name is Mike Groth. You can visit me at www.attainablegrowth.com for more information, and I look forward to hearing from you. Take care.